So perhaps we can move to the next speaker, Professor Hyun Chol-rae. He is a professor in Samsung Medical Center, South Korea, and he is a famous name in tumor ablation therapy using ultrasound. He will talk about ultrasound-guided liver ablation, basic beyond knowledge.
Good morning. Assalamu alaikum. Thank you for your kind introduction. It's my great honor to give a talk with such distinguished faculty, Professor Maloney and Professor Cho. It is very nice to meet my old friend, Dr. Altai Sakar. He stayed with us for 3 months, maybe 15 years ago. It's my great honor to give my small talk in this session. Let me brief my message. Unfortunately, I don't have any ultrasound image. Even this meeting is ultrasound society, because my topic is really basic. I believe all of you in this room already know very well. The keyword is basic should be first. Ablation is widely accepted as one of the treatment for early HCC, and also many novel techniques will enhance the therapeutic outcome and safety. However, basic is more important for successful ablation rather than novel technique, including contrast-enhanced ultrasound, fusion, and elastography, and so on. Basic is well known to us, but we often forget it. Please always start from the ground. Novel is sometimes useless without the basics. Basics should be always first. As we all know well, basics include careful selection, precise planning, accurate placement of electrode, and optimal ablation, and learn from each case. So let me start with the first one, careful selection. Careful selection of the best candidate, the first door to successful ablation. HCC treatment guidelines are proposed mostly based on tumor size and tumor number and tumor location, including perivascular and subcapsular. However, there are many more factors for the best selection. See the forest first, and then see your tree. Feasibility of ablation show a broad spectrum from the best candidate to the absolute contraindication. So tailor-made selection strategy is the smart way to achieve the best outcome. Objective system for feasibility assessment, unfortunately, is not available. Objective feasibility assessment is useful for referral physicians or patient as well as ourselves. Maybe 15 years ago, we proposed a simple feasibility assessment guideline, including electrode paths, adjacent organ, tumor size and conspicuity, and heat sink effect. So we called POSH score. It was published in the European Journal of Radiology, but unfortunately, the score is not so much popularized. Anyway, at least we need to have this kind of your own feasibility score system to more scientifically approach feasibility assessment. According to the feasibility, you can score just like child score from A to C15. Depending on the score, you can select many more alternative treatment or assistance techniques. Objective system for feasibility assessment is necessary, but is not so much assessed in the literature. So we need make a kind of nomogram, and finally, AAIE-based selection criteria. Best candidate of local ablation for HCC is a single, smaller than 3 centimeter, a well-defined conspicuous tumor ultrasound, and non-perivascular, non-subcapsular, and non-perihilar tumor. However, many more tumors are located in the potential candidate. So we have to more objectively stratify the feasibility. Select a proper weapon depending on the enemy is really important, from best candidate to absolute contraindication. For best candidate, we can ablate successfully with just a single ablation without fusion or even contrast-enhanced ultrasound. But the feasibility is decreased, we have to consider other combined treatment, including TACE, and even we have to switch to radiation or proton therapy. The carefully selected enemy that you can clearly kill with just a single shooting, even with a combined treatment. Let's move on to the second one, precise planning. Planning is the half of successful ablation. We cannot build this kind of gorgeous building without the detailed planning. If you decided to ablate, please make the most detailed plan as much as you can. Planning consists of three major parts, from tumor and patient and procedure itself. For patient, first we have to meet the patient in outpatient clinic, not in just ultrasound room. We have to consider all kinds of basic clinical information from age to tumor markers. And then regarding the tumor, we have to assess more in detail beyond the just tumor size and location. The precise review of all image is really important, and measure the detailed diameter in 3 dimensions and tumor margin to assess the microvascular invasion and perivascular structures and safe electrode path and conspicuous and guiding modality is a really important factor. Always we have to consider the tumor in 3-dimensionally. About the procedure, we have to decide the patient position, anesthesia, energy source, guidance, ultrasound or CT, if we need to use the fusion and contrast-enhanced ultrasound or artificial fluid. And furthermore, we have to choose the type of ultrasound approved, the electrode path, applicator type, and exact placement site, including exact intercostal space. And we have to decide the central through or marginal touch or no touch technique. And also we have to specify the tumor ablative margin depending on the tumor size. Detailed planning is really important to achieve the best result. Make a document, specific document on the detailed planning on your medical record before starting ablation. And finally, mind training, so-called rehearsal of procedure is really important. I recommend 3 times rehearsal at the time of planning. The second one is a D-1 day. Before the day of your procedure, you have to check patient again and include the planning result. And finally, after draping of the patient, you have to perform the final planning. So 3 times a rehearsal in your brain is really important. So planning is the half. Let's move on to the third one, accurate procedure. Without accuracy, sometimes ablation is sometimes useless because ablation should be, we have to get the complete ablation if you decide to treat by ablation. So accurate placement of electrode is the most critical part to guarantee the best local tumor control. Like Swiss watch, puncture placement is really important. Always we have to consider 3D dimension. If you decide to treat with just a single ablation, we should try to our best to insert electrode really along the central core of the tumor, from anus to mouth. It is easy to say, but technically, even if we use the contrast-enhanced ultrasound or fusion, it is not so easy. 100% central puncture. So we have to try to make this kind of accurate procedure. If you decide to 2 electrode, not just lawfully use the chopstick, you should insert accurate place. For example, 3 o'clock and 9 o'clock. If you place 3 o'clock point and, for example, 10 o'clock point, the ablative margin is not circumferential. But on ultrasound evaluation, it is impossible, even using the fusion technique. That's why the basic is really important. Final advice for accurate placement. After insertion of the electrode, before starting the ablation, please ask yourself 3 times. It is really accurate? Are you sure? Are you sure? Are you sure? 3 times. If you answer for third question, yes, from that time you can push the button. The next one is stay optimal. Ablation is really minimally invasive. That's why we always should be optimal, not just excessive. Please remember this battle to fight against HCC is not just a single battle, almost a million battles, almost until the patient life. As we all know, HCC continuously recurs even after the curative resection and even transplantation. That's why optimal is important. This is not just about size or speed. The optimal and safe ablation is really important. The patient is also fighting for liver function. We should always remind liver function is more important for patient overall survival. So that's why we have to try to save the patient's poor liver as much as we can. In that sense, we have to cook the tumor completely, but we have to save the liver as much as we can. There are so many tools to cut this kind of a fluid. So depending on type of fluid, we have to choose the smart weapon, smart knife to achieve the best result. Even if you choose the ablation to treat HCC, stay optimal. We don't need to take this kind of luxury car to visit to our neighbor house. Extreme versus ablation, I would say optimal is always better in most procedure. Extreme and optimal. Circumferential ablative margin is much more important than just simply big enough ablation. Balance between the complete and safe ablation is the most important, as we all know well. Don't forget our poor liver. Many more treatments will be surely awaiting near the future for this patient. My last message is to learn from each case. Already we are doing this kind of process in our procedure, but I have to emphasize one more time. Case is the best teacher, I think. Planning and post-ablation, before ablation and after ablation. We usually check this kind of immediate imaging study, and we say just, oh, good, just well done. But there are so many messages in this the single slide CT, post-ablation CT. We have to learn many things. So after one procedure, please take your seat in your monitor and ask maybe 10 more questions. Always we have to compare between the planning and post-procedure CT. Usually there are big difference, even you are expert on ablation. For example, there are many differences between planning and post-ablation. So this is very important. If you find this kind of difference, fine, we have to find what is the reason. What is my limitation? Using even the novel technique, fusion and contraction and ultrasound. What is the difference? Another example, the planning and the ablation, I use the 3 electrode. The ablation zone like this. Looks good. I think definitely I get enough circumferential ablative margin. But here is a P4 area we cannot evaluate. After the ablation on coronary scan is really like Dunkin' Donuts, very nice ablation. But if you see here, this is it is not the circumferential ablation. This area is ablative margin is less than 5 millimeter. So we have to make even extra scan like Dunkin' Donuts like that. On sagittal scan, as you can see, the posterior margin is asymmetrical. So this is our limitation. Okay, why is the difference? We have time for considering. Ask yourself the following question. My placement of electrode was really accurate? Ablation zone is optimal or similar to your plan? Was it excessive? If so, why? Was it insufficient? If so, why? Circumferential ablation margin? If not, why? Any mistake compared to your original plan? Any unexpected event? What was missed at planning or procedure? How will you do if you have the same procedure next time? What is the lesson from this case? So please write down after each procedure what I have done well and what I have done wrongly, and the final one, what is the lesson from this case? If you have one thing to be well done, please repeat it same. Bad done, please don't repeat for next patient. If you have any lesson, please share with your colleague, including this kind of conference. Learn from each case. So novel is really beautiful like this. I love this flower, but we should always remember the root. The basic beyond the novel is sometimes more important than just novel. Okay, let me conclude. Ablation is a curative for small HCC. The novel technique is necessary for better outcome. However, the basic is much more important. Thank you for your attention.
Thank you, Prof. Nice presentation, nice talk. Any question from the ground?